Good morning. Today we're going to be talking about the inflammatory response, which is quite complex because of all of the different cells, as you can see in Chapter 7, that is involved with this response, the inflammatory mediators and the protein systems. And however, this process is germane to many different diseases that we encounter in nursing. Certainly one that I put on the syllabi is rheumatoid arthritis. And however, this process is hopefully this review of inflammation and the protective response helps the body. It involves different types of symptoms, the redness, which is due to the increased blood flow in the area, the heat, again, because of the blood flow, the pain because of the sensitivity of the receptors, and the chemicals that, like histamine, that come to the area or the site of injury that stimulate the receptors and cause pain, and the prostaglandins, and edema, the increased capillary permeability, and as the fluid goes from the intravascular space to the interstitial space, you have edema and swelling that presses on adjacent organs and can cause some pain and sometimes loss of function and ischemia. Then you have protein systems that are involved, clotting systems, the complement and the kinins and their role in controlling inflammation. And then you have the phases of the wound healing with regeneration for different types of wounds, such as lacerations. There are different types of organs involved, and first certainly is the first line of defense, which is the skin. This is the physical barrier that is involved in the body, and the most prominent, and the mucous membranes. The skin being a thick, impermeable layer of epidermal cells that overlies a rich vascular bed. And so the skin cells, as new ones are produced, push the dead ones outward, and the dead cells provide a waterproof layer because of the keratin in those dead cells. But of course, somebody who has a laceration or opening of the skin is open to infection. Another part of the inflammatory response, major group of cells that are involved are the neutrophils. And this is a member of the granulite series of the white blood cells, and is named for its characteristic staining of the white blood cells. It's the predominant phagocyte that, as a result of chemicals that are drawn to the site of injury, it draws and calls the neutrophils to that particular area of site of inflammation within 6 to 12 hours after the initial injury. And this chemotactic factor specifically and rapidly attracts these neutrophils to the area. Neutrophil is a mature cell that's capable of division, but it's very sensitive to its environment, which is so therefore it's very short-lived. Eventually it becomes part of the exudate and the pus, and is carried away from the body by the lymph system. Then you have different parts of the immune system. There are 5 structures. You've got the bone marrow, where the B cells are produced and developed, and they migrate to the lymph nodes. You've got the lymph nodes that are along the vessels that concentrate and filter the fluid that drains the body. And they remove the bacteria and toxins from the circulatory system. You've got the thymus located in the mediastinal area between the lungs, and secretes a group of hormones that enable the lymphocyte to mature into T cells. And you've got the T cells that are very tough and attack foreign bodies and abnormal cells and regulate the cell immunity. And then you've got the spleen, the very largest of the lymph organs, that is a reservoir for blood and macrophages. I want to talk a little bit more about the chemotaxis. Chemotaxis cytokines are the largest and the greatest perfume of the body. Some individuals wear enough cologne that their presence can be detected long after they're gone, and the same person can be tracked down in a neighboring hall if one just follows their nose and follows the perfume. Well, in this sense, the cytokines their cells are attracted to the site of injury by following these inflammatory cytokines. So they're the noses that are following this perfume in the area. Then you've got the second line of defense, inflammation, and this is the first response to the injury, and it's seen in tissues with a good blood supply that are vascularized. It happens pretty rapidly within seconds after damage occurs, and like I said, involves cellular components and chemical components, and is very nonspecific. It takes place approximately in the same way every time, depending on the injury. Like I mentioned, you have the classic local symptoms, which is heat, swelling, pain, and loss of function. And so how I briefly described it before, the vasodilation is the increased size of the blood cell in the area, which causes the slower blood viscosity and increases the blood flow to the site. And you have the increased, as a result of the blood flow, chemicals are attracted to the area. The chemicals, which are basically the release of histamine, prostaglandins, and other chemicals that are in quite detail in your textbook, they attract the neutrophil, the macrophages, and the monocytes to the injured area. And these chemicals alter the vascular permeability and cause dilation of the vessels. So you get the vasodilation. And the increased capillary permeability causes the redness and the heat. The blood vessels become more porous and fluid leaks out of the vessel and exudate, causing swelling and edema at the site of the injury. And the blood flow becomes more viscous, flows more slowly, and you have a concentration of red cells in the area, causing the erythema, or the redness to the area. The white cells, like you said, migrate to the injured area and here to the inner sides of the capillary walls, and then they pass through the capillary walls and phagocytize the bacteria and the dead cells. And pus may form and debris is removed from the area. The clotting factors enter the injured area also, and oxygen and nutrients in the injured area increase, and plasma, like you said, leaks into the tissues. And sometimes this swelling can restrict movement in the area and increase the temperature and the metabolic rate of the cells. And this all is part of the healing process. I want to talk a little bit about the complement proteins. And the complement system is a process that involves the blood plasma proteins, approximately 20 of those, and enhances the action of the antibodies. They circulate, these proteins circulate in the blood in an inactive state, but when foreign substances invade the body, they become activated. And there's 5 complement system proteins together forming a large molecule or a membrane attack complex. And this attack complex becomes embedded in the plasma protein membrane of the bacteria, opening up, creating an opening in which water flows. And the influx of water causes the bacterial cells to swell and burst and die. And these complement proteins also stimulate the vasodilation during the inflammatory response. Some of the complement proteins also increase the permeability of the vessels, allowing those white blood cells and plasma to quickly come to the infected area. Others serve as chemical attractants, drawing the macrophages, the monocytes, and the neutrophils to the infected area where they phagocytize. They're like little Pac-Man, the foreign debris. And still others bind to the microbes and form a rough coat on the invader that promotes phagocytosis. Inflammation can cause local symptoms, like I mentioned, the heat, the swelling, the pain, but it also can cause systemic manifestations of acute inflammation. And basically those are the fever, which are partially induced by the cytokines and that are released from the neutrophils and the macrophages, And you've got leukocytosis, the increase in the levels of the circulating leukocytes, and increased levels of the plasma proteins. And those are the systemic manifestations of acute inflammation. And certainly as a result of the fluid and debris, cellular debris going into the interstitial tissues, you have the exudate. And depending on the stage of the inflammatory process and the type of injury, you've got serous, serosanguinous, purulent, hemorrhagic exudate, and describing the different types of cells that are involved. Then in terms of, there's also a difference between the acute and chronic inflammation. Basically, the acute response is self-limiting. It only continues as long as the threat to the host is there, and usually about 8 to 10 days from onset to healing. If the acute inflammatory response proves inadequate, the chronic may develop and persist for weeks, if not months. So specifically, the difference between acute and chronic is the timing, where the chronic lasts 2 weeks or longer, regardless of the cause. And then once the inflammatory response comes to an end, you have the resolution as the return of tissue to the normal structure and function. And repair is sometimes causes some scar tissue formation in the area. Damaged tissue proceeds to the resolution or restoration of the original tissue if very little tissue is lost and the injured tissue is capable of regeneration and has the proper cells and vascularity to the area. And resolution and repair occurs in 2 separate phases. You have the reconstructed phase, in which the wound begins to heal, and the maturation phase, where the healed wound is remodeled. And dysfunctional wound healing can be caused by ischemia, a lack of blood flow to the tissues, excessive bleeding, where you have excessive fibrin deposits in the area, or a disorder such as diabetes. Wound infection, inadequate nutrients to the area, numerous drugs, or altered collagen synthesis. And certainly dehiscence you have seen if you have a surgical wound where the sutures, disruption of the wound and the wound pulls apart at the suture line. You have dehiscence. You could have a contracture, a complication of the wound where a deformity, a shortening of the collagen in the scar tissue that can cause dysfunction in the area. If you look at the age considerations related to the innate immunity, if you look at the newborn child, newborns have a depressed inflammatory responses. The neutrophils are incapable of the chemotaxis and lack fluidity in the plasma membrane. The complement systems are diminished, especially components of the alternate pathways in premature infants. You have the monocyte and the macrophage numbers are normal, but the chemotaxis of the monocytes is delayed. There's a tendency of infections associated with the chemotaxis defects. For example, abscesses caused by staph and candidus. There are diminished oxidative and bacterial responses in those stressed by the uterine infection or respiratory insufficiency. And there's a tendency to develop severe overwhelming sepsis and meningitis if they're infected by bacteria that the infant has not gotten any maternal antibodies from the mother. And then on the other extreme of the age group, the elderly, you have a normal number of cells of innate immunity but diminished function like phagocytosis. You have increased incidence of chronic inflammation related to a lot of pro-inflammatory mediators. And impaired wound healing often associated with chronic disease. Many have diabetes, peripheral vascular disease, or cardiovascular disease. And then, of course, the use of medication if they have Usually when you get older, you